Hello, how are you? Welcome to the second part of immediate complications of FGM and their management. My name is Winnie Barawa. In this session, we are conducting a series on female genital mutilation, which is supported by the Girl Generation in collaboration with ACAP and the University of Nairobi. This is a movement that tries to end the practice of FGM in our communities, specifically in Kenya and in Africa. So stay with me all the way to the end. We began this part of immediate physical complications of FGM, and we have discussed the above. We have discussed on severe pain and tissue injury and how to manage it. We've also looked at hemorrhage and how it can lead into hemorrhagic shock, and also the immediate management that we can initiate, including the BMOC and also the Dr. ABC, which are very critical, and then they emphasize most on maintaining the vitals, and also fluid replacement and blood transfusion. Now, in this session, we are going to look into cases of infection, tetanus, acute renal infection, retention, and how we can go ahead and manage these particular cases. So be with me as we move one condition at a time. So let's start with infection and septicemia. So we are told that most infections are identified in the type 3 of FGM, and there are common infections that you can watch out for. For example, infection from HIV and AIDS. There's Clostridia tetani, that is from the cases of tetanus. You can also have chlamydia, trachomatis, there's gonorrhea, there's pallidums, candida vaginalis. Basically, there are several types of infection that you can be concerned of. However, these are the most prevalent ones. And infection could be from any bacteria, virus, or fungi, or parasites that get to have an entry at the tissues that have been damaged during the FGM process. So when it comes to infection, we can start the first investigative procedures, like understanding first which infection the woman has been infected with and what are the best procedures to start from. So with management of infection, we may not have a cut across starter management that you can do. However, you first at least try to confirm which particular type of infection the lady has been infected on. So how do we manage? The basics of infection, number one, is you can do vital signs, and most of the time with vital establishment, you're able to establish like the temperature levels. Of course, in cases of rising temperatures or fevers, these are indicative of infection setups. So you can check the vital signs and assess her progress in terms of the infections, and then assess the vulva if you want to confirm any signs of infected wounds and cases of urinary obstruction. Then take a vaginal or a pus swab or a urine sample to just test and identify the specific organism that the woman could have been infected on. And then secondly, if you suspect septicemia, that is infection in the blood, now you can take blood samples for culture and sensitivity so that you can confirm the specific microorganism that has gained entry for the lady. And then with that, you can now start specific management that will target the main bacteria that the lady has been infected with. However, on the side, you can treat the lady with a broad spectrum parenteral antibiotics together with together with analgesics. This is for pain focus. And if the wound is infected, you can look into antisepsis management of the wound, like clean it or maybe on continuous days or alternate days. However, the wound care has to be antiseptic or aseptic. So follow up with the client after several days. You can maybe assess after 7 days or more. And if the client persists, then you can refer for further treatment. So basically also counsel the client on danger signs and when to return immediately. So with infections, it can depend because there are mild infections, then there are cases where there's severe infection cases where we're talking about sepsis. And if the infection gains entry to the bloodstream, then we talk about septicemia, which is now a case which will force us to work with broad spectrum antibiotics or medications that will be more strong and has high potency for clearing the microorganism that is in the blood at that particular moment. Then the fifth type of immediate physical complication is the acute genital tissue swelling. So in the cases where we have the cut happening, there's some moments where the tissues can get injured, but then this can also bring some local inflammatory responses, which leads to swelling. So tissue swelling, can be due to the force, the damage, or generally the inflammatory reaction on the cut area. So the genital swelling can also be due to infections. So because of infection, it can stimulate an inflammatory process that now can lead to the tissue to swell. So how do we manage the tissue swelling in this regard? So with acute genital tissue swelling, mostly for any disease, the first advice is to assess. So assess the area and determine the extent and the cause of the swelling, and then inspect the vulva carefully for any signs of infected wound, and check for anything that might be contributing to the infection. So if you diagnose that there's an inflammatory response to the cutting, then you can give anti-inflammatory medications, or you can give which can be given through different method. It could be intravenously or it could be orally, but basically give anti-inflammatories to assist with reducing the inflammatory process. This is to reduce the swelling and also treat the site of the injury. If the client in this case has some case of severe swelling and there's blockage of urine passage, then you can insert a Foley catheter to clear the opening and allow urine to flow out. So with acute genital swelling, this is just the emphasis bit that this happens due to the issue of inflammatory process that has occurred around the genital tissues, and part of this could be causing the urethra to close or the urine passageway to block, and the woman may not be able to pass their urine properly. So in such cases, then you can go in with a Foley catheter. And then the last part is on acute urine retention, just like the way we've explained in the genital swellings or in the tissue swelling. With swelling, it tends to really cause blockage of these pathways, and to assist more, then you're advised to do the Foley catheters. So you're told when you're dealing with the acute urinary retention, use the whole cause of this retention could be different factors. And in this case, we are being told that urinary retention may be the result of the injury which has caused the genital swelling, could be also due to pain, that is severe pain, which is now stimulating fear of passing the urine and also leading to occlusion of the urethra. So for example, for a client who have undergone the type 3 female genital mutilation or the infibulation in this case, sometimes the urethra can also get occluded, and this can cause urine retention. So acute urine retention occurs due to various factors, and one of it is the swelling and the inflammation around the wound. So the management of this condition will be based on what you observe, or basically what are the severity of the retention. Is it chronic? Is it acute? But in this case, you're going to focus more on the acute urine retention part. So you're told first, determine the cause of the retention. Is it the injury? Is it the swelling? Is it the blockage of the urethra? Is there something that is leading to this retention? So use appropriate skills and techniques to encourage the client to pass urine, such as turning on tap water, which is known as one of the biggest stimulator for passing urine. If she's unable to pass urine, maybe because of pain or fear, you can now start managing pain. So you can talk about pain management by administering strong analgesics. And also on the case of anxiety and fear, you can encourage this patient on personal encouragement and support. Basically, here we are looking at allaying the anxiety, or keeping this client calm so that she can have the trust and she can be calm enough to pass her urine. If there is all the methods have been tried and tested and the lady is not able to pass urine yet, then you can insert what you call a Foley catheter and leave it there for 2 or 3 days to just assist with emptying the bladder. However, in clients who have undergone infibulation and the urethra has been blocked, or the urethra has been obstructed or sutured, then you can advise the woman to prepare for opening up of the sutures. And this procedure, we call it de-infibulation. This is in simple term, opening of the sutured area of the this is opening of the sutured area of the vaginal areas, that is. So if the retention is due to injury of the opening of the urethra, you can refer for surgical intervention, which now will be more organized and well done. So cancel your client on danger signs and when to return immediately. Follow-up is very key and critical for all the clients. So always release your client with a return date so that you can follow up on their management and see if it is effective. So that marks the end of the immediate complications. Please don't forget to subscribe if you've not done that. Share this in your platform, guys. I always encourage you to share. And if you've also not checked well, down there we have different ways you can join our community, or you can also send super thanks. You can support our work by sending super thanks, or you can also be part of our community by sharing this work in your platform. Comment and like our video. Thank you very much and see you in our next lessons. Bye bye.